Toppie Faurie is the Managing Director of Codicom, a leading payment solutions platform dedicated to enhancing the medical financial process in South Africa. We all know that as private practice owners, cash flow is a big issue because people don't always pay for the services they provide. So this is the talk you need to listen to if that is a problem that you find in your practice. His journey into the medical billing sector began in January 2016 when he started as a billing consultant in his wife's practice. It was here that Toppie first encountered the complexities of the industry, sparking his passion for improving healthcare financial processes. With a strong commitment to excellence and continuous learning, Toppie studied extensively to deepen his expertise in the financial aspect of the medical industry. He holds multiple qualifications, including basic and intermediate clinical coding from Cape Town University, advanced clinical coding from the DUX Academy of Healthcare, and anatomy, physiology, and terminology from the same institution. Additionally, he has completed CPT Coding training at Cape Town University and has studied practice management and medical debt recovery at the Dalmor Medical Administration Institute. Toppie has extended his knowledge abroad, studying the transition to ICD-10 AM, ACHI, and ACS 11th edition in Australia. Under Toppie's leadership, Codicom has become a trusted partner for healthcare providers, streamlining payment processes and significantly improving ethical financial outcomes for medical practices across South Africa. His dedication to the industry and innovative approach continues to set Codicom apart as a leader in medical payment solutions. Welcome, Toppie. Can we please give him a round of applause?
I'm so privileged to address everybody today and, in this wonderful setting. Thanks for the organizers for arranging all of this. I hope that what I'm about to present to you today will find resonance with you and equip you to maximize the full potential of your practice. These are the two things that the normal public out there thinks that a healthcare practitioner has, but in most cases doesn't. One is time, the other one is money. I'm married to a surgeon, so I know. First of all, we're going to discuss the clinical or diagnostic coding, which is your time, and then I'll move over to the procedural coding, which is your money. So what is coding and why is it important? Before I started my journey in the payment solution side of the medical industry, I was doing billing for a lot of doctors, and around the braai fire, people would ask me, what I do for a living. And when I say to them, no, I'm a medical coder, and no one knew what that was. And I had to basically tell them, if you have a look at your account statement from your medical or from your doctor, then all those codes on there, all the values and all that stuff, that is what I do. And I found it strange that no one ever thought that somebody actually has a job just to do that, because we form such an integral part in the medical industry. So, but it goes much further than just sending codes to the medical aid and expecting payment. Spare a thought for the poor person that's sitting at the medical aid that needs to understand what exactly happened to this patient, what was done, what interventions were performed to get this patient back to normal health. So if you think back to the Great Wars in the last century, where they used Morse code, if I can use that as an example, if somebody sends you a message via the Morse code and they go tick, 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 dot, tick, 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 dot, then at least if you are trained, you can understand what they're trying to say. But if they send you just that one lone tick sound, then you will be confused and you will not understand what are they trying to say. So why are we doing this to the medical aids? I've seen healthcare practitioners literally, if I can use as an example, throw a code at the medical aid and expecting payment. And unfortunately, it doesn't work that way. They need to understand what happened during this episode of care. Whether it's in your practice, in your in-rooms practice, or whether it's in a hospital setting, the schemes need to understand. So when we talk about medical coders, I always refer to it as we are storytellers. We explain to the schemes exactly what happened to this patient, what was done to this patient to get him back to normal health, all in codes. And I've seen some horrendous coding in my life, but I also don't blame the healthcare practitioner, because the healthcare practitioners have not had any formal training in coding, either clinical or procedural coding, and it's not their fault. But I'm going to elaborate a bit on that a little bit later in my presentation. We need to ask ourselves, what is diagnostic coding? Let's start at the foundation today. It's the process of translating written descriptions of a patient's medical conditions, illnesses, and injuries into standardized codes. Standardized codes, typically using a system like the International Classification of Diseases. When you look at the South African coding standards, and again, I want to pause here. Being married to a surgeon, I saw some of the books that she has in the house. Those books are almost 2,000 pages long. You know, it's massive things. Our South African coding standards is 107 pages long, and that includes the acknowledgements and the abbreviations at the end. So it will be easy meat for you guys to just work through it and make sure you understand it, because that is your guideline. I want to take you to the ethics of clinical coders, because I think this is so important that we understand that clinical coders, whether it's in a specialist practice setting, whether it's in a hospital setting, whether it's in a GP practice setting or a dentist setting or whatever, whoever does the coding, if it's you, the doctor, that does the coding, you are bound by the same ethical guidelines as what normal people like myself are when we do medical coding or clinical coding. So we don't have time today for me to explain everything to you, but I'm just going to run through it quickly to give you an idea of what they say. So the clinical coders shall be dedicated to providing the highest standard of clinical coding and billing services to their employers, clients, and patients. Clinical coders shall perform their work with honesty, attentiveness, responsibility, and not exploit professional or other relationships with employers, employees, clients, and patients for personal or undue commercial gain. Clinical coders shall refuse to participate in or conceal any illegal, unlawful, or unethical processes or procedures relating to coding in any aspect thereof. Clinical coders shall participate in ongoing education to ensure that skills and knowledge meet the appropriate level of competence. Clinical coders shall observe policies and legal requirements regarding patient consent, confidentiality, and processing of patient-related clinical information and all personal information. Clinical coders shall apply the South African coding standards and other official reporting requirements for the purposes of clinical coding within what is lawful and ethical. Clinical coders shall only assign and report codes that are clearly and consistently supported by practitioner documentation in the healthcare record. Clinical coders shall ensure that clinical record contents justify selection of diagnosis, procedures, and treatment, consulting clinicians as appropriate. Okay. So, unfortunately, we don't have time for a proper coding class today. So I'll just give you some of my tips. Now, these work in any setting, and I'll use an example. For instance, when we talk about a primary diagnosis, which will be the first one that I'm going to talk about now, when I talk about a primary diagnosis, in a GP setting, when a patient comes in there complaining of a sore throat, for instance, that is your initial finding. But when you start with your investigations and you see that this patient actually has a tonsillitis, that will be your final finding. That will be your primary diagnosis. Because what they say here is that it's the diagnosis that was primarily responsible for the need for treatment found at the end of the episode of care. So do not, your initial findings that you have, do not code those. Code the ones at the end of the episode of care. Whether it is your hour consultation with the patient at the end of that hour, that is a code that you use, not your initial code. Code the comorbidities. Don't be scared to code the comorbidities, because comorbidities has a direct impact on the level of care, resources used, and in a hospital setting, the length of stay. So code if a patient comes in with his tonsillitis, but he also has diabetes and high blood pressure, or hypertension, then, code all of them as comorbidities. It will give the scheme an idea of what you are dealing with. Okay. Go to the highest level of specificity. I want to say, don't be scared to tell the schemes exactly what is wrong with this patient. I had a client a couple of years ago that got angry at me because I wanted more information on the gastritis. And my client said to me, "But Toppie, it's gastritis. What don't you understand from gastritis?" From a coder's point of view, I said to a doctor, there are 18 different codes for gastritis. Hemorrhagic, alcoholic, the list goes on. And I said to her, please be specific and tell me. And she did. And I could have coded the correct diagnosis. Next one is keep clear of unspecified codes. These are normally your 0.9 codes, your unspecified codes. Try and say clear from there. I know in a GP setting it's very difficult. In a specialist setting you can send stuff to the or biopsies to the pathology people and all this and get a decent report back. But in a GP environment, we only have 45 minutes or 30 minutes. I don't know how long. I don't know how long you take to examine your patient, but in that period of time, you might not have all the information that you're looking for. But see if you can be very specific with as far as possible. And also, please remember when I speak about your 0.9 codes, it's not all the 0.9 codes, please, because your hernias are also 0.9 codes, but they refer to with or without gangrene or obstruction. The last one, or the second last one, please, if you are the coder or if you have somebody in your practice that does your coding, please spend some time with them and give them all the information that they need. Because, at the end of the day, you're going to spend a couple of seconds with your coder, or you're going to spend hours writing letters of motivation because the scheme doesn't understand what happened during your episode of care. And then the last one is my personal pet hate, is use the correct modification of the ICD-10. I've seen so many healthcare practitioners out there. They just go on the internet and choose the one from Google. That is the United States modification of the ICD-10. Most of those, not most of those codes, a lot of those codes are being rejected in South Africa because it's not valid in South Africa. South Africa has its own modification of the ICD-10. To give you an example, when I studied through HEMA in Australia, in the South African modification of the ICD-10, we've got between 39 and 43,000 different codes, diagnostic codes that we use. Australia has, in their Australian modification, 88,000 codes that they use. So their codes are much more descriptive, and I think it's a bit better than ours. But let's not get in there. But the point I want to make is you cannot use those codes, which is freely available on the internet if you search for it. You cannot use those codes in a South African setting. So go to the Department of Health, go to our good friends at SAMA and all the other governing bodies. Get the South African edition of the South African ICD-10, that modification. So in closing about diagnostic coding, I just want to say, if your diagnostic coding is 100% correct and the schemes understand what exactly you are trying to tell them, then it will free up so much time for you to attend to more patients, or even better, spend some time with your family. Is there any questions on diagnostic coding before I move over to procedural coding?
Any questions on coding?
Hi. What ICD-10 browser would you recommend then for South African use?
Sorry, can you I can't hear you.
What ICD-10 browser would you recommend for South African use? Yes,
it's the one that's available from the Department of Health. That is one. There's also companies out there that where you pay a subscription. Like I'm not sure if I'm allowed to use other companies' names here on this platform, but SpaceNet, for instance, when you subscribe to SpaceNet, they've got their whole list there. Sama has the medical doctor's coding manual that you can buy online as well. That is a South African modification. I think the Sama doctor's coding manual is, last year I bought one for, I think, 900 Rand, and that's for the whole year. Everything is in there.
Is the World Health Organization ICD-10 direct browser not the one we subscribe to? No, because the World Health Organization's ICD-10, different modifications come from that because it is country-specific or region-specific. Like Australia, with the AM modification, they've got Australia, New Zealand, Singapore. I think India falls under them as well. But it's only those areas. Those codes won't work here, or some of those codes won't work here. And that's what you don't want. You don't want to use a code that the medical aid rejects because that code has been discontinued, or we don't have a code like that in a South African setting. Do you perhaps know, so for the Department of Health, do you just go to the Department of Health?
Yeah, you can Google the ICD-10 Department of Health, and it will come up. The whole thing will come up there. But I would actually suggest that there's so many different companies out there, like a SpaceNet, like Sama, and all those people that has the correct ICD-10 modification for you. Some of them do charge a subscription or a once-off payment. But, then at least, you've got the correct one. And it goes further than that. It's not just the codes. It is sometimes most of these guys have an explanation of those codes and in which setting you can use it, and which codes you are not allowed to use with other codes as well. That is why I love clinical coding so much. It's like solving this riddle when you go into intensive coding and stuff. But that's something for another day.
Yeah, and I'm sure every association like Sama and Otasa also has. I'm sure the physio. Do they not have one? Any other questions on coding? There's one at the back there.
Hi, just a question on ICD-11 coding. I know in 2023 there was some mention that there was going to be a change or an adoption of ICD-11 coding. Is there any update on that?
She's really bringing the big one out to you, Toppie.
Look, what I'm going to say now is my own personal opinion. I don't think we're going to see ICD-11 quickly because there's too much that still has to happen for that. I've heard that some of the big hospital groups are starting to train their staff on ACHI, which is replacing your CPD, but that's more the procedural coding and stuff. I did have a meeting with somebody high up in the coding industry in South Africa on Friday, and that person is convinced we won't get ICD-11. But don't take my word for it. So I'm just answering your question. Okay.
I think just to clarify on ICD-11, because we are members of the World Health Organization, and it's actually a directive that comes from them, the ICD-11. And I think South Africa, the reason why that word got out is because that is one of the NHI things. They want us to be on ICD-11 for NHI. So I would say the skeptics of NHI and saying how long it's going to take for us to get NHI, I think you can pair that and ICD-11 together. But there are other things, like you said, like ACHI, and then there's also International Classification of Funding, ICF. Like we all are going to have to be trained in that. And especially GPs, no offense, I'm an OT, but GPs especially, that's a bit of a foreign language because it's not medical model. It's based on more the holistic health model because it's looking at function and activity. So those are all things to just be aware of. It's not only the ICD-10 you need to be aware of that's coming. Any other questions? Okay, I think we can carry on.
Okay, I see we are a bit pressed for time, so I'm just going to jump into the diagnostic coding side of it. So your diagnostic coding, this is where your money lies. If you do proper coding with the diagnostic side, you can bill for whatever you are rightful to bill for. But let's talk about money. I've never seen an industry that is so scared to speak about money. Because, doctor, you've studied for all those years, and when you walk past the patient, you are too scared to say, listen, this is going to cost you so much, or this is going to cost you so much. I understand that. But let's have a look. Before I get there, I just want to tell you, I don't know if you know who Zig Ziglar is, but he made a brilliant comment one day, and he said, money is not everything, but it ranks right up there with oxygen. So if you don't have money in your practice, your practice will not survive. Okay, we can go, Craig, next one. No, previous, sorry. So what is procedural interventional coding? It is a process of assigning specific codes to identify and describe the medical procedures performed on a patient. Coming back, just go back one slide, sorry, Craig. This is what I wanted to show. In the SAMA Doctor's Coding Manual, I found this. This is what SAMA says about money. It should be noted that doctors are free to levy fees to what they regard as appropriate and justifiable for services rendered. So there you have it. Let's not be scared to charge patients, within boundaries and ethical guidelines and stuff for the service that we have delivered to them. Okay. So I cannot stress enough to the value of having a competent person that knows exactly what they are doing, that is running the billing aspect in your practice. If it's you that's running the billing practice or aspect in your practice, then I would ask you to equip yourself and educate yourself. There are so many courses out there. I mean, a stupid guy like myself could have done a couple of them and passed them easily because I understood it, and it's so easy. So please, invest in yourself or the person that is doing your billing. Now, I wanna before I shock you, I wanna tell you this or speak about this incident a couple of years ago. When I was still doing billing for doctors, a specialist contacted me, and normally when a specialist contacts you and says, Toppie, listen, I've got trouble, you need to come and help me with my billing, then you can know that it's not trouble, it's something a bit bigger than just trouble. So what I normally did was I would go back 4 months, because you've got 4 months to submit a claim to the schemes before it expires. So I would normally go into a practice and go through everything that was billed for the last 4 months, get the patient's files, go through the clinical notes and see, has everything been billed for that you are supposed to bill for? In this specific instance, the poor lady, and I don't want to say it's her fault, because she never got the education. The doctor never invested in her. So I'm going to create a scenario for you now. The patient came in a hospital setting, was admitted as an emergency immediately into ICU, intubated, ventilated, and all that stuff. So when I looked at the account statement that this patient was billed for, then I had a look at it, and I saw on the top is what the lady. Now this lady she was also the receptionist, and this doctor was a subspecialist. So there's already something wrong there. You have to have a dedicated person that does your billing in a practice like that. So she went and she billed 0173, which is your first hospital consult. 145, which is a non-emergency visit for a first day in hospital. It totaled 1,196 Rand 20. When I read through the clinical notes and I saw what actually happened with this patient, I reversed that bill and I billed the correct codes for that. Now remember, this is 2020 prices. So 0173, your first hospital visit. 0147, your emergency code for a hospital. 1208 is your first day in ICU for the primary practitioner. And your 1212 is your ventilation on the first day. That totaled 8,411 Rand and 10 cents. So the difference is 7,214 Rand and 90 cents. Now, this is no reflection on me. This is to give you an idea of what is happening out there, and it's still happening today because people don't invest in their staff or invest in themselves to equip them to maximize the potential of their practice. If you do make use of a medical bureau, Craig, Next one. If you do make use of a medical bureau, make sure, test them, make sure that they are up to date with the latest legislation and show you that they are absolutely competent to do your billing for you, your diagnostic coding. Because that is the area where when you do lose money, you're going to lose a lot of money. Okay, that's it. Any questions?
Thank you so much. Does anybody have any questions? I wanted to ask you about the ICD-10 codes again, and you said to avoid using unspecified. Is there a difference between unspecified and not otherwise specified? Or there's another code where it's like...
Not elsewhere classified.
Yeah, something like that.
Yeah. There's a huge difference. Unspecified basically says to you that we don't know. We are still doing investigations, so we cannot give you a final answer. Nowhere else classified means that it doesn't belong to that group of codes that you are using, basically. But that is, it's a very deep coding clause type of question that you asked me now.
And then I know can I get an indication here of how many of you here are actually GPs? How many? Can you just show hands? And then let's see of the allies. I know we've got physio. Any other physios? We've got a podiatrist over there. Anyone else a podiatrist? Two podiatrists? What other professionals do we have? Any occupational therapists? Nursing. Okay. Any other professionals? And then what about practice managers? Any practice managers here? This obviously applies to you. So, I just wanted to know also, obviously with GPs, this doesn't really apply, but, on the ICD-10 browser list of the World Health Organization, there are also codes that are not necessarily medical codes. So there are codes, I can't remember the code out of my head like you, but it's Z something with, you know, when you are, so like when I have a consultation with the parent of my client, I can charge for that. And there's a specific code because I'm obviously not doing a procedure with a client.
Yeah.
So are we allowed to use those kind of codes? There's also codes like about unemployment. There's a burnout code, those kind of codes.
Look, according to me, but I'm just a clinical coder, but I'm not the one that makes the decisions. But according to me, anything that is in the current ICD-10 list, South African modification, should be accepted by your schemes. The business symposium where I spoke, when was it, 2 weeks ago? I got the same question as well. And I just feel that is where your society should go and approach the schemes, because I hear about a lot of rejections when you use a certain code, which I think is absolutely, it's a valid code and you should be able to use it. And, but you get manipulated by the schemes because some of these codes, they don't accept. If I can use an example, I had an incident with a person that had a cellulitis for a surgeon client of mine. And because we coded all the comorbidities as well, the account got rejected because he has obesity as well. And for me, I don't know, that's morally incorrect. It's just wrong. You know, obesity is a clinical finding. It's a diagnosis, and it should be there according to the South African coding standards. You have to code the comorbidities, especially in a hospital setting. So I think that is the area where your society comes in and they have to approach the schemes and say, listen, we need to clarify this. And,
any questions? We have a question over here.
Hi.
Hi.
With that example that you had where there was
I can't hear you.
with the example that you just had up there where there was the first hospital visit and then the emergency visit, I think. There was two different codes, the 014, I think it was 0147
and 0147,
yes.
yeah.
So what I find sometimes is that when you code for a hospital visit and an emergency hospital visit, the medical aids don't always pay together. But I see there's a slight difference in those two codes that you have.
Sorry, there's just a lot of reverb on this side. I'm really struggling to hear you guys. Sorry.
Yeah, she was just asking because she said sometimes the schemes don't allow the two codes together, but she said that she noticed there's a slight difference in the emergency code.
Yeah. So if I can explain that to you quickly, your 0145 in a hospital setting both of those codes, 0145 and 0147, one refers to an emergency, your 0147. Your 0145 refers to a non-emergency. So that's somebody that is in hospital already, for instance, and a physician is asking the surgeon to come and examine the patient. So that's not an emergency because, well, in most of the times it's not an emergency because the patient is already in the hospital setting. Those two codes must be charged with your first hospital consultation, your 0173 all through to 0175. Does that make sense to you? If your medical aids, I've also seen in my almost 10 years of doing billing for doctors that sometimes the schemes also make a mistake. It's human nature. So maybe just call them again and say, but listen, this is what the guidelines of SAMA says and the NHRPL and all of those people. So please explain, how can you reject this code? Because they cannot, they're not allowed to.
So I'm going to ask you a bit of a difficult question, but I first want to find out, I'll come to you now. How many of you here are actually private practice owners? Can I get an indication? Put your hands up, don't be shy. Okay, so there was a slide where you said that SAMA says that we are at liberty to set our own pricing. So I don't know if all of you are aware, the government has recently applied for a block exemption, which basically in layman's terms mean they are wanting to regulate healthcare pricing. So they want to create committees that will collectively decide what a GP can charge for each code or whatever practitioner you are. So I just want to know from your perspective, Toppie, I'm putting you on the spot, but as the husband of a surgeon, what are your views on that and how do you think that will also impact coding in your practice?
Look, my honest opinion about that is, and thanks for putting me on the spot there, but is that if you can say, for instance, there's a reason why people sign with medical aids because let's say a Bonitas offers you 130% of medical aid rates. There's a reason you go for that because you get 30% more than what they are willing to pay. I'll give an example for you. This year, I think MedScheme, FedHealth Bonitas, they charge for a medical aid rates for a gastroscopy. I think it's 820 Rand. Now, I just find it, it's actually laughable to think that for that half an hour or how long it takes you to do this gastroscopy, you have to take that patient's life in your hands for 800 Rand. The risk of perforation is always there. There's always other risks that are there. If something goes wrong, it goes wrong for 800 Rand. So I am totally against it, Tasneem. Let the doctors decide for themselves. There is a rule in the NHRPL that says you can afterwards discuss with the scheme. Let's say, for instance, you had a hernia repair that you've done, and it took you 6 hours because it was an obese patient. There was lots of other comorbidities. So you can go to the scheme and ask them, listen, you need to pay me more for this because this is not your normal setting. But the schemes don't. So I think if somebody must decide rather than you as a healthcare practitioner, and I've also heard that there are no healthcare practitioners sitting on those boards that are going to decide or wanting to decide. So they do not understand, what you healthcare practitioners go through when you perform a procedure. It doesn't matter what procedure it is, the responsibility that you take, and they want to justify it by giving you an entry level remuneration. I'm sorry, I cannot support that.
Thank you, Toby. We had one more question over there, and then we're going to wrap up. Thank you.
Yeah, thank you. Thank you very much for an opportunity to ask a question. I've got a very lighter one. Maybe you can just clarify me about the money that I lose. If you see a patient in ER and admit this patient in early hours in the morning, and in during the days, 7 o'clock, 8 o'clock, you go and do a follow-up visit on this patient. I see the medical aids give us a bit of a problem to be claiming a follow-up visit when you have seen the patient in early hours, because it's a same day thing. Is there a way how we can go through that, or is it impossible? We can't claim. That's the first one. The second one, it's you've got a patient in hospital. You see a patient in the morning. In the afternoon, he complicates. You go back, you rush, you stabilize him, and you arrange whatever that you arrange. It's another emergency visit that you've done on a patient, but it's on the same day. Is there a way that this can be claimed, or because you've seen this patient once, you can't claim anything? Maybe you can enlighten us.
Yeah, look, it's a great question. Unfortunately, and this is one thing that the schemes are very strict on, is that the rule says, I think it's Rule G of the NHRPL, says that it is within a 24-hour period. So they normally cut off at 12 o'clock at night. So if you see him on a Tuesday and you see him on a Wednesday again, yes, you can charge him again. But if you see him twice on a Tuesday, you can only charge for the first time. That's all.
Thank you so much, Toppie. That was very insightful. Can we please give him a round of applause? Oh, did you have a question? Oh, we have time for one quick question.
It's not a question, it's a comment. I work at the South African Society of Physiotherapy, and regarding the exemption, there is actually open for comments until the 28th of March. So I think if people are feeling strongly about it, then please comment, because it is open still.
Absolutely. Agree with you.
Yes, thank you so much for reminding us of that. It is open, so please do send your comments. You can't complain if you don't complain, right? That's the saying. So thank you so much, Toppie.